Welcome everybody. We are going to begin module number 1, medical, legal, and ethical issues. Sergeant Gaudino, Manchester Police. I'll be your instructor for this module, and at the end we will have a quiz to test your knowledge. So part of the National EMS education competencies, we're going to speak about consent, refusal of care, confidentiality, advanced directives, possible criminal actions related to our behavior, evidence preservation of crime scenes, statutory responsibilities, mandatory reporting related to juveniles and the elderly, ethical principles, moral obligations, and end-of-life issues. So going through this training, be sure to view it through the eyes of a certified EMR. So if you're taking this course, you are a certified police officer and you are required to be an EMR. However, when you are going through these slides and modules, ensure that you are viewing the questions or the situations through the lens of someone administering EMR standards. So just an introduction for medical legal. Above all else, do no harm. So if you're out there and you are doing a good job and you're doing care to the best of your ability with the equipment that you are given, you should have no legal consequences if you are out there. We all know that we're open to liability and lawsuits through just our job as a police officer, but those generally don't amount to anything. So as long as you consider the concepts of doing no harm, providing all your care in good faith, provide proper constant care, be compassionate to your patients, and always maintain your composure, you should not have a problem. So when we're going through medical legal, we're not out here to say that you're going to get a lawsuit every time that you administer medical care. It's just a reminder that there is some standards that you're going to have to confine to in order to be in accordance with the state standard. But no one's going to hang you out to dry if you're providing all your care within good faith. So the first term that we have, and you may see this in the quiz, is duty to act. So what duty to act means is that if you're employed by an agency, so if you're taking this, you're employed by a police agency such as Manchester, and you're certified as an EMR, which we're all required to be, and you're dispatched to the scene of a medical call or an accident, you do have a duty to act. So you're sitting in a parking lot, you're typing reports, and dispatch sends you to a 1031 accident with injuries over up by the mall. So right then and there, you hit all the criteria that you have a duty to act. So you're employed by MPD or a police agency, you are certified as an EMR, and you are dispatched to a call for service. So right there, those three criteria, you have a duty to act. So what it means about your duty to act is that you must proceed promptly to the scene and render emergency medical aid within the limits of your training and available equipment. So this goes back to our first slide where if we provide good faith medical care, then you should not be open to potential liability. So sometimes you're doing cruiser checks and maybe someone didn't double check the oxygen, so it's not at the appropriate PSI or it's at 0. You get to a scene where someone requires oxygen, you go and grab the O2 tank and it's at 0. So immediately you would shift to a different intervention, whether you use the bag valve mask or wait for a secondary unit or EMS to arrive with another O2 bottle. That is providing medical care within the limits of your available equipment. So again, if you do it in good faith with the cards that you were dealt, then you shouldn't open yourself up to liability. And by yourself, I mean the agency as well. So failure to respond or render care leaves you and your agency vulnerable to legal action. So if you get dispatched to that 1031 up by the mall, but you decide that you want to get your Dunkin' Donuts coffee on the way, you are failure to respond or render care. So you're grabbing that Dunkin' Donuts coffee, you get up, and it turns out that the patient required CPR, and they end up passing away as a result of that. We'll get into a couple more terms later on that will cover approximate causes if you fail to render your duties as applicable. So long story short, you have a duty to act, and you're dispatched to the scene of a medical call, and you're on duty, then you need to provide, respond promptly to the scene. Standard of care is the manner in which you must act or behave. So the standard of care must meet two criteria. You must treat the patient to the best of your ability. You must provide care that would be considered reasonable. And a prudent person with similar training would provide under similar circumstances. So your standard of care, it sounds much like our use of force. So after the fact, it's viewed through the lens of the police officer who, a reasonable police officer, what would they do under the similar circumstances? Would they administer the same use of force or act in a similar way? So the same thing with EMR is that you're certified, you show up on scene, and you have a gunshot wound and you put a Band-Aid over it. A reasonable and prudent person with similar training would not put a Band-Aid on a gunshot wound. Or if they require rescue breathing, but you put on a non-rebreather mask at 15 liters per minute, which we know is not proper ventilation, that is not what a reasonable and prudent person with similar training would do under similar circumstances. So someone requires rescue breathing, everyone is going to do the bag valve mask. Someone's having difficulty breathing, everyone's going to do a non-rebreather nasal cannula to supplement that oxygen. So it's what a reasonable and prudent person with similar training would provide under the circumstances. So that's the standard of care. So now the scope of care, the people that are tasked with coming up with the scope of care is the U.S. Department of Transportation, Emergency Medical Responder Education Standards. So believe it or not, the U.S. DOT actually comes up with our scope of care. We have medical protocols and standing orders. So that's kind of our EMR certification and what we're allowed to do and not do under our certification under the state. And we have online medical direction. So online medical direction, more applicable if you're riding on an ambulance. When I used to ride on the ambulance back in New York, if I had someone with chest pains as an EMT and I administered the first dose of the heart medication and they required a second dose, first dose is covered under my medical protocols and standing orders because as an EMT, I can give nitroglycerin to someone who has chest pains and their vital signs are within acceptable range. But to give that second dose, if I'm still en route to the hospital, I need a doctor to sign off on it. So for online medical direction, I would pick up this phone in the ambulance and it would be connected directly to an on-call doctor at a given hospital. Online medical direction, I would give their vital signs, the chief complaint, how we found them, how they're doing right now, and what my intentions are. So they'd be like, yep, sounds good. I will sign off on giving another dose of nitroglycerin, and then you would administer to the patient and be good to go. Offline medical direction is something that our area medical director specifically authorizes us to do under our certification. So they can give us more leeway or tighter leeway. So if our medical director at ECHN, when we first came out with TECC for the police department, hyphen chest seals, tourniquets, the use of MPAs in certain circumstances, that all had to be authorized by our medical director because all our TECC equipment in our go bag, not all of it is approved under our EMR standards. But our medical director specifically gave us a memorandum that said that, hey, offline medical direction, tactical situation, you may use the go bag and the given supplies as long as you're trained in them. So online means that you're specifically talking to a doctor, and that is primarily your ambulance crews or fire department if they want to give additional medications. But more on the EMS side or the EMR side, we work on offline medical direction, which is from our medical director over at ECHN. Some of the ethical responsibilities and competence. You always want to treat a patient ethically, and that means by doing so in a manner that conforms to accepted professional standards of conduct. So part of being an ethical EMR is that you have an obligation to stay up to date with your skills and knowledge. So if you get your EMR certification, you fall asleep in your EMR refresher classes, you breeze through the quizzes, you breeze through the videos, and you don't pay attention, and then you screw up on something, you are not being ethical with your patients. You have an obligation to stay up to date on skills and knowledge. So if myself or another EMS instructor send out an update, or you read an article that has like the new way of doing CPR that is being attached to your certification for Connecticut, you need to learn those skills and knowledge. You need to do periodic reviews of your performance and assess your techniques. So if we get called to an overdose and we're first on scene, first responders, we start doing CPR, we're bagging the person, administering oxygen, maybe putting in an OPA or MPA into the airway. At the conclusion of that call, you should be reviewing your performance and assess your techniques. And part of that is that you participate in quality improvement activities, which I would say is that you debrief with your crew that was there, so your other officers that are administering CPR, and you're like, oh, hey, Gaudino, nice job on the ventilations. Maybe you should connect it to maximum oxygen before you start bagging, or it would have helped if you told me that I need to press a little bit deeper when I was doing compressions on the patient. So that's reviewing your performance and assessing your techniques. If you have any questions or you're unsure about something, you need to ask someone. So ask an experienced EMR, an experienced officer, or an EMS instructor if you need to clarify something that you have questions with. As usual in our job as a police officer, you want to evaluate your response times. So if there's a shorter route, you want to make sure that you shave those seconds off, driving safely, and you get to the call as quickly as possible. So if we're going up by Talon and Chapel, we're not going to take Parker Street to Talon Turnpike to North Main Street to get to Talon and Chapel. You always want to be like, oh man, maybe I should have taken that route instead of taking a longer route. So similar to FTO training, you always want to kind of analyze your actions and see where you can make improvement. Additionally, ethical responsibility in your competence is that you want to take continuing education classes. So ideally, I know we don't do EMS on a daily basis for our primary jobs, but just like how we request training through the police department, whether it be laser, crash investigation, drugs, interview and interrogation, you should be active with pursuing continuing education classes. So that's kind of tied into staying up to date on your skills and knowledge. So maybe every 2 to 3 years isn't enough time for you to gather all the updates and to refine your skills as an EMR. Maybe you need to request an EMS class or request another class that's related to EMR training so you can stay up to date on your skills and knowledge if you need that. But if you feel like that you're proficient and you work a lot of overdoses, a lot of difficulty breathing, then maybe you don't need it, but it's something to think about. This is something that we know in our profession. Ethical behavior requires honesty, so always provide complete and correct reports to other EMS providers. Never change a report, whether verbal or written, except to correct an error. So if you didn't do something, don't make it up. So when we do the handoff, first on scene, we're doing CPR, it's an overdose. Maybe we didn't get a chance to administer oxygen, or be able to do the bag valve mask. We just were able to do compressions only CPR. But we know that during CPR we need to do ventilations and chest compressions, but maybe due to an officer safety concern or due to timing, we are unable to get our medical bag and administer oxygen. I would hope that when the paramedic arrives from the fire department or ASM, that you're not gonna give your report and say, oh yeah, we gave max flow oxygen on the bag valve mask and we provide ventilations with 30 chest compressions and we alternated. Just be honest and say, hey, we're only able to do compressions only CPR, and everyone will absolutely understand. As long as it's not a blatant disregard. Usually the fire department and ASM, they are right down the street, and there should be no problem with you being open and honest with what you had to do. If you had to secure the scene and you weren't able to do chest compressions on an overdose, then just let EMS know that, hey, I was securing the scene, it wasn't safe for me to render chest compressions, I was waiting for another officer, but then you guys showed up, so then they can take over, because some of your actions beforehand, whether you did them or did not do them, will dictate their actions. So if you lie about it, not only are you being unethical, but you are messing up the standard of care that the person of equal or higher certification is going to be rendering on that person. So you always want to be open and honest with your verbal or written reports. Never change a report except to correct an error. So along the same lines, if you didn't do it, don't write it down. So in your next gen report, if you happen to jot down chest compressions to 2 ventilations, but you didn't do ventilations, then document it as you did it. If you have to make a change, make sure you make it in writing and say it was an error. But other than that, as long as you're open and honest, you should not have any issues. So consent for treatment, we have 3 different types. So to define consent for treatment, consent simply means giving approval or permission. So when I was initially getting certified as an EMR back in 2006, or as an EMT, and I was doing my practical skills, I had to act like a robot, do my practical skills, and I would come up on scene. This adult, say, hypothetically had a broken leg. As they're screaming in pain, I literally had to put on my gloves, ensure the scene's safe, and go up to them and be like, hey, I see that you've broken your leg. Can I treat you? And 99.9% of the time, they say, yes, you can treat me. And that's what's called express consent. So if they're conscious and they actually let you know, verbally or non-verbally, that he or she is willing to accept treatment, that is express consent. So when you show up on scene and you have an overdose and you want to give them a non-rebreather with 15 liters per minute oxygen, before you administer that, you should be asking them, and it should be documented that you said, hey, I see that you're having trouble breathing. Can I fill up this non-rebreather and put it over you? It should help you breathe better. And the response is yes or no. The patient must be of legal age and able to make a rational decision. So if it's a juvenile, we're going to get into that in a second, and they must be able to make a rational decision. So we have a lot of experience with this with our EDPs or our people that we're taking into protective custody. If they can't make their own decisions, we're going to treat that as implied consent, and we're going to treat them. So going back to the first line of express consent, the patient actually lets you know verbally or non-verbally. I forgot to mention that an example of non-verbal communication that a patient may give to you is hypothetically if someone's choking. So they're conscious, they're legal age, they can make a rational decision, but they actually can't talk and communicate that they want you to treat them. So the universal sign is that they're going to wrap their hands around their neck and they're going to give you the indications that they can't breathe, that their airway is obstructed. So at that time, we would take that as express consent because they're letting us know non-verbally, based on their conduct and behavior, that they need help, and then you go into the Heimlich maneuver. So that's express consent. they're alert, conscious, legal age, able to make a rational decision, and they tell you verbally or non-verbally that they would like treatment. The other two, we have implied consent. Implied consent is they can't specifically authorize or decline medical care, but a reasonable person can assume that if they were alert and oriented, they would want medical care. So the patient does not specifically refuse emergency care, and do not hesitate to treat an unconscious patient. So you show up on scene and they're unconscious. You don't know why they're unconscious. They can't talk to you. They can't give you consent. Are you just going to sit there until they become alert and oriented for you to ask them to be treated? No. We call that implied consent. If they were alert and oriented, a reasonable person would say, hey, I'm unconscious, please help me. So if they're unconscious, you're going to work under implied consent, or if they can't talk, or if they're alert only to pain, or if they're alert only to verbal stimuli, then you would take that as implied consent. Consent for minors under the law, minors are not considered capable of speaking for themselves. So we have a couple extra steps for minors. So little Johnny has a broken leg or a broken wrist, and you show up on scene. Technically, you must wait until a parent or legal guardian consents for the treatment. If permission cannot be obtained quickly, do not hesitate to give appropriate medical care. So again, Johnny has a broken leg. If mom's on scene, hey mom, you mind if I treat him? Yes, go ahead. You got consent to treat. If he's at the school and we can't get in touch with mom, or Johnny's in an intense amount of pain, we're not going to wait to get in touch with mom or dad to administer medical care. So again, it goes under, would a reasonable parent want you to treat this child? So if they have a boo-boo and little Johnny's refusing, maybe we can take an extra couple minutes to get in touch with mom or dad. But if he's in excruciating amount of pain or he's unconscious, then we're going to work under implied consent, because it's being implied that if mom or dad was on scene, they would want you to help out their son or daughter. Consent for mentally ill patients. We have a lot of experience with this with our peers and our now our PREs, the police request for emergency evaluation. If a person appears to be a threat to self or others, place this person under medical care. Know your state's legal mechanism for handling these patients, which almost always defaults to a police officer to commit them and take them into protective custody. Do not hesitate to involve law enforcement agencies. So again, when you're viewing these PowerPoints, I gave the disclaimer at the beginning that you're viewing this through the lens of an EMR. So we know what we have to do for protective care, for PREs, for peers, for taking protective custody. But for an EMR, if you have a question that says, hey, what should you do if you have someone who's a threat to themselves or others, 9 times out of 10, the EMR would retreat and wait for law enforcement. But us being law enforcement, we know that mentally ill patients, we can take them into protective custody if we have probable cause to believe that they're a threat to themselves or others. So state's legal mechanisms, we have PREs and police officers, clinicians, other crisis counselors, they will be doing those. So as an EMR, you refer it to law enforcement. Patient refusal of care, very important, because we encounter this quite a bit, and this probably is the highest liability that we have. So this is the bread and butter of our medical legal module, is that if a person is mentally in control, they have a legal right to refuse treatment. So this is if they want to leave the hospital, if they want to say screw you and they don't want you to treat them, if they want to say screw you to the fire department and they don't want to be treated, if they're not falling under the criteria of an emergency committal and protective custody, then they have the right to refuse care. We're not just an extension of a doctor or an extension of the fire department or the paramedic. we have to make our own individual decisions if we're going to use force to force this person to do something, whether force them into the cruiser, bring them to the hospital, force them into an ambulance, and they get brought to the hospital. You need to be very careful. This is the highest liability that we have in regards to our not only being a police officer, but as an EMR, is patients are allowed to refuse care. By the book, if someone refuses care, you want to take the extra minute, not just turn away and say, all right, see you later, hope for the best. If a patient refuses care, you want to help the person understand the consequences of refusing care. So sometimes you'll see MFRE, the paramedics, they'll say, oh, you don't want to go to the hospital. Then, hey, just so you know, you have a high blood pressure, you have low blood pressure. If you go home and you're alone, you could pass out and just be stuck there on the floor. You should be getting checked out. That's the paramedic attempting to have the person understand the consequences of refusing care. They talk about the treatment. Hey, you're just going to the hospital. It'll just be a couple hours. They just want to put you on an EKG and see what's going on. If nothing's wrong, you'll be out in a few hours. The reason that the treatment is needed, you have an obnoxiously high pulse, and that is not normal. If you stay at this in this direction, we don't know what's going to happen. You need further medical care. You need a doctor to check you out, not an EMT or a paramedic. The potential risk if treatment is not provided, hey, you could pass out, you could be alone, you could die. Like, you need to get checked out, and any alternative treatments that may help. So back to patient refusal of care. In my EMR classes, when I teach this block, I always reference back to an incident that I had when I had a couple years on the job, because I was in a very interesting situation that opened myself up to a lot of liability, but luckily it ended with the agency and myself not having any liability. We get called to 365 Balkan Hills Drive, which, if you do not know, is one of our major apartment complexes by the mall. We get a call for a diabetic emergency. So the individual is highly intoxicated. He's a mid-20s male, hanging out with his friends, having a crap load of alcohol, and since he is inebriated, he doesn't monitor his type 1 diabetes, which we know that you need your balance of your sugar and your insulin levels for a type 1 diabetic. So we get called because his friends say that this individual is unresponsive. So me and another officer, we respond up there. We see a couple of friends. They're frantic, a little under the influence, nothing crazy. And the paramedic sees this unconscious individual. They test his blood sugar. It's low, maybe about 20 or 30. If you catch type 1 hypoglycemia pretty quickly, and you just give some dextrose, you can revive them relatively easily. So the paramedics gave some D50, and almost immediately the patient woke up, and he was upset with the police interventions and the paramedics. They started an IV line. His blood sugar shot up, and he was within acceptable range for a diabetic. Paramedic says, hey, I started a line. You need to go to the hospital. They looked at a 1.5-year-old veteran Gaudino and said, hey, you need to force him to go to the hospital because I started an IV, I started interventions, he has to go. And I came from administering medical care in New York, and New York actually authorizes you, if a medical individual or a doctor deems that you need to go to the hospital, or if it's in your best interest to go to the hospital, a doctor can force you to go to the hospital. So I was like, all right, you have to go to the hospital. The paramedic said so. And this patient was ready to fight us. He's like, no, I don't want to go. Like, I'm fine. I'm a type 1 diabetic. He didn't fall under the being under the influence. So we couldn't take him into protective custody for for being intoxicated or overly under the influence. So he was a person who was mentally in control and has a legal right to refuse treatment. Luckily, instead of opening up a lot of liability for the agency and myself, during this the patient's rant about not wanting to go to the hospital, he expressed that if he was to go to the hospital, he would kill himself. Then he fell under danger to himself or others, and it fell under an emergency evaluation. So at that time, we were able to force him to go to the hospital. However, if he didn't make that statement and fall under the PC for a pre, then we would essentially be kidnapping this person and forcing them to go to the hospital. Because there's nothing that says that he can't refuse treatment. Even if the paramedic started a line, gave drugs, think of how many times you went to an overdose and they got Narcan 3 or 4 times, they came to and they're like, yeah, I'm all set, I don't want to go to the hospital. They can do that if they're mentally in control. So just remember, highest liability, patient refusal of care. I don't care what MFRE says, what eighth utilities say, what the paramedic says, what the hospital says. Each situation is on you. And don't just assume that you have the legal ability to seize someone. You need to come up with your own probable cause to make the decision to exercise your authority to seize that person. Another thing that we may encounter quite a bit is an advance directive. So advance directive is a document that specifies what a person would like done if he or she becomes unable to make his or her own medical decisions. So the types of documents that we have are a living will, a durable power of attorney, and a do not resuscitate. So a living will is merely a document drawn up by a patient, a physician, and a lawyer, and it states what types of medical care the person wants or wants withheld. A durable power of attorney for healthcare allows a patient to designate another person to make decisions about their medical care. So if the patient is incapacitated, they may say their husband or wife or a family member can make the decisions to provide an intubation tube, to put them on a ventilator, to take them off a ventilator. So the durable power of attorney mainly falls on hospitals, not pre-hospital care, because we're not going to spend crucial seconds or minutes to verify the validity of a durable power of attorney while we're on scene during an emergency. The only thing that we may encounter that we may need to consider is a DNR, so a do not resuscitate. This is a written request giving permission to medical personnel not to attempt resuscitation in the event of a cardiac arrest. I've seen it before where there is a terminally ill cancer patient and they're on their last breaths and their quality of life is not good. They're confined to a bed or a ventilator, and that patient may make the decision that they will have a do not resuscitate. So don't do rescue breathing on me, or don't do CPR and rescue breathing on me if I happen to go into cardiac arrest. That is their decision. But again, if a family member's on scene and your patient's unconscious and requires CPR, are we going to wait to verify that DNR order? When in doubt, always provide CPR. So if you're unable to determine if an advance directive is legally valid, begin appropriate medical care. Some states have systems in place, such as bracelets, to identify patients with advance directives. They might have the Star of Life that says DNR. Although that doesn't suffice as proof that they have a DNR, it might point you that you need to investigate a little bit more. Sometimes people have what's called vials of life, where they keep a lot of important medical documents. And the vial of life typically is kept in the fridge, because it's the one place that medical personnel are trained to look. It's a little vial in a fridge. They open it up. Hey, there's a DNR. Hey, it's a medication list. But if you go up on scene and a family member is crying that they have a DNR, hey, where's the DNR? If they can't provide it within seconds to minutes, you were starting CPR. And nothing is stopping you from starting CPR, and then ultimately you stop CPR after you deem that they have an appropriate DNR. But would you rather be caught doing CPR and providing life-saving measures in the presence of a DNR, or would you rather be not providing CPR and you can't verify a DNR and that person passes away? So I'd rather always err on the side of providing medical care, and I'll leave it to another police officer who shows up, or I'll leave it to a paramedic with a lot more experience. They can look for the DNR and be like, yep, go ahead, Dino, you can stop doing CPR. They have a valid DNR, doesn't have stains on it, it's not expired, and doctor signed off on it. Then you can stop CPR. Abandonment. The definition of abandonment occurs when a trained person begins with emergency medical care and then leaves the patient before another trained person takes over. We may run into this a lot because by nature of being a police officer, we get called to hectic situations where we may initiate medical care, and then due to officer safety concerns, we would stop medical care. Abandonment occurs when a trained person begins emergency medical care and then leaves the patient before another trained person takes over. Example that comes to mind, you're called to a 1031, airbag deployment. The driver requires some sort of intervention from an EMR. However, you're the first responding officer, you need to protect the scene and the scene integrity. So obviously your safety and the safety of others comes first. So although you checked in with the patient, it would not be considered abandonment if you have a safety concern. However, situation where you could get into some hot water is you initiate medical care on the 1031 operator, airbag deployment. They need you need to hold spine stabilization, and then the case officer says, hey, can you get that person's insurance information? So the scene's already kind of status quo, it's safe. You start medical care by means of holding neck stabilization, and then you leave that patient and you start your administrative investigation, or you gather documents. No go. So as an EMR, you start medical treatment. The scene is safe. That is your patient until someone who has at least as much training arrives, takes over. So at least as much training as you, or they are above your certification. So you're holding neck stabilization. You can't say, hey, Joe Citizen, how about you take over? I have stuff to do. If he's not certified, it's a no-go. So once you start medical care, you have an obligation to stick with that patient, absent a safety issue, until someone of equal or higher certification comes to take over, aka MFRE, volunteer fireman, or ASM. Person dead at the scene, we're pretty well versed in this, but a quick review for the EMR part of it. If there's any indication that a person is alive, you should begin to provide care. So if you ever have any doubt, don't be the EMR, which is the lowest level certification, that says, oh yeah, he's dead, I'm calling it. We only call it once a paramedic arrives, hooks him up to an EKG, and determines that he's in asystole and he cannot be revived. Asystole meaning flatlined. As an EMR, you're only able to not provide medical care unless there's an obvious decapitation. So motor vehicle accident or a suicide via gunshot wound to the head. If you look at the person and you're like, there's no way that they can survive this, then okay, you don't need to provide medical care. If they have rigor mortis, so if their extremities are stiff and they're not moving freely, that's an indicator that they've been down for a while. Tissue decomposition, so again, it's obvious they've been sitting there for a while, they're bloated, you know that you're not going to revive them. Then okay, you do not need to provide care. Dependent lividity, so the blood's not pumping anymore, and naturally the blood is going to pool around the lowest point of the body. So if they're supine or laying on their back or laying on their bed, then you're going to have a lot of dependent lividity on their the lowest part of their body. So their back, the backs of their legs, it's going to show that the blood is pooling, and that means that they've been down for a while. But again, if you ever are in doubt, then provide medical care. Because I'd rather provide medical care and have that EMT hook him up to the EKG and say, yep, he's dead, good to go, let's call it, here's my certification number, my name, here's the time, and then have him stop me. But if you're just standing around a body, he hooks him up to the EKG, and he has remnants of a heart rhythm, then it's not gonna look good. So when in doubt, provide medical care unless obvious decapitation, rigor mortis, decomp, dependent lividity. So again, through the lens of an EMR, if any signs of death are present, you can consider them to be dead. It's important to know your protocol your department uses when dealing with patients who are dead at the scene. We all know what to do with a dead body on the scene. Negligence occurs when the patient sustains further injury or harm because the care administered does not meet the standards. So you're administering care outside of your scope of care or your standard. For you to be determined negligent, you need to have a duty to act. So if you're working, you have a duty to act, and you breach that duty. Say you're getting that coffee at Dunkin' Donuts and resulting in further injuries to the patient. Say they're down, they require CPR, and you didn't provide CPR, and they die, and they determine that the extra downtime without CPR because you went and got your coffee, that is negligent. So again, you need to have a duty to act. You breach that duty, resulting in injuries, and they can narrow down that cause to it's your fault for breaching that duty that caused that extra harm to that patient. Confidentiality, very important, especially in kind of modern times. Patient privacy is of the utmost importance. Most patient information is confidential, including patient circumstances, how you found them, what's going on with them, what their patient history is, your assessment, your interview about previous medical conditions or medications, and the types of care that were given. Information should only be shared with other medical personnel. So we run into this a lot in the police culture. We go to maybe a crummy house and you determine that they have A, B, and C disorders, or they're taking this medication, or you find a multitude of very private, confidential medical information. Naturally, as police officers, we like to go to our coworkers and debrief about the call, specifically the people that are not involved in the call. So absent it falling under kind of official law enforcement intel, going back to a friend, a coworker, and say, yeah, like over at this address, they have hepatitis or they have HIV. That is all protected information. The only reason you would be sharing that information is when you're giving your brief to the higher level medical level of care, such as EMT or paramedic or ASM, or hospital if you're briefing them on an emergency committal or an evaluation. Other than that, it should not be shared with anyone. In certain circumstances, you may release confidential information to designated individuals, mainly for hospitals, but pre-hospital care, that's going to be your higher level medical care, your brief with your hospitals or your EMTs or firemen, because that's all exempt from confidentiality because you're passing on medical care to that person. If you see a question about it, the Health Insurance Portability and Accountability Act of '96 is HIPAA, so it strengthens laws and for the protection of privacy, of healthcare information, and safeguards patient confidentiality. So there's a prosecutable statute or federal law that prohibits us releasing information about an individual to someone that's not on a need-to-know basis, which is why when we want to get information from MMH or Hartford Hospital or St. Francis, we need to do a search warrant to get those toxicology results, that blood samples, urine samples, medical records, because that's all covered under HIPAA. And hospitals are very strict about that, and we should be very strict about that too. All right, we're finishing up now. Good Samaritan laws that protect citizens from liability for errors or omissions and giving good faith emergency care. Varies considerably from state to state, may no longer be needed, provides little or no legal protection for a rescue or EMS provider. So Good Samaritan law, it's for your citizen who is not certified, they don't have any medical care. They have these protections in place that protect them from being prosecuted or sued in the event that the patient maybe suffers additional injuries or something else. So Good Samaritan laws, the thought behind it was in states where there's extended response times, either for sheriff, deputies, police officers, EMS, firemen, extended ETA. So sometimes if you call for an ambulance, maybe for a motor vehicle accident on the side of the highway, you could be waiting 15, 20, 30 minutes for your first responder to show up. So those states come up with Good Samaritan laws to encourage your average citizen to stop, check in, render medical aid. Because it could just be they need CPR. It could be that they need direct pressure. It could be that they need spinal stabilization. It could be that they need to be pulled from a fiery wreck before the car explodes. And a lot of people, especially in modern times, they will look at that accident and be like, I don't want to be sued. So they just drive right on by, and they have no duty to act, and nothing is ever going to happen to them. But in those remote areas, we want people to be encouraged to stop and render aid. And they have Good Samaritan laws in place to protect those all-star citizens that stop and render aid, so they won't be open to lawsuits and that their actions will be protected. So if they're being pulled from a burning vehicle and they end up being paralyzed because they have a spinal issue, that citizen cannot be sued because they were acting under good faith and the Good Samaritan protection laws, because we want to encourage people to stop and help. Documentation, similar to NextGen or our police reports. Your documentation is the initial account describing the patient's condition and the care administered. If you administer medical care as a police officer, there should be a legal record of it somewhere. If you did CPR, if you administered oxygen, if you assisted a paramedic with chest compressions, it better make it in its way to NextGen. Because if they have an audit or a lawsuit or something bad happens to that person and they trace it back that you didn't document anywhere that you provided medical interventions, you're going to be in some trouble. So document it. It serves as a legal record of your treatment. Additionally, it's quality control because you can evaluate the quality of your care provided. I should have did 15 liters per minute instead of 12 liters per minute, or I gave 3 liters per minute via nasal cannula instead of 6. And along the same lines, it should be clear, concise, accurate, and readable, just like our police reports. Documentation should include condition of the patient when you found them. Were they on the bed? Were they on the floor? Did they fall? How'd you find them? The patient description of the injury or illness, so what are they explaining to you? If you take vital signs, you want to make sure that you include that. The interventions that you gave, MPA, OPA, CPR, oxygen, direct pressure, tourniquet, agency and personnel who took over the treatment, since we want to make sure it doesn't fall under abandonment. You want to document who took over. Hey, I gave CPR until I was relieved by paramedic A, B, and C from MFRE. And then anything else that anything else that you believe should be documented. Also, any infectious disease exposures. So here at Manchester Police, we have an exposure form that we've been using a lot recently for COVID-19. So if you're exposed to any bodily fluids, anything that is communicated via airborne, you want to make sure that it makes its way into not only your report, but also into our MPD specific exposure form. So get in touch with a supervisor, they'll sign off on the exposure form and submit it up to our field services captain. So just a quick recap, as an EMR, you have a duty to act when you're dispatched onto a medical call as part of your official duties. You should understand the differences between consent, express consent, implied consent, consent for minors, mentally ill people, and a patient's right to refuse care. Advanced directives gives the patient the right to have care withheld, such as a DNR. You should understand the concepts and definitions of abandonment, negligence, and confidentiality, as well as the purpose of Good Samaritan laws. Certain events that deal with contagious diseases, abuse, illegal acts must be reported to the proper authorities, which primarily would be either your brief to a higher level of care or follow up in your official capacity as a police officer. And we have crime scene considerations, which I took out that part because we are all familiar with that. Just looking through my notes, scope of practice is a set of regulations and ethical considerations that define the scope of legally allowed care and priority for the well-being of the patient. We talked about consent, refusal of care, leading cause of liability. They must be alert and oriented to refuse care. DNRs that do not resuscitate, a legal document usually signed by the patient and a physician who states that the patient has a terminal illness and does not wish to prolong life through resuscitation efforts. And that is it for the review. This is the conclusion of module number 1, which is medical legal, and coming up will be your test.